Our next speaker is Dr. Eric Feduska, who is assistant professor and serves as the director of the CVICU at Jefferson University Hospital, also program director of the Adult Critical Care Medicine Fellowship there. He earned his Doctor of Osteopathic Medicine from PCOM in 2013, completed residency at Jefferson Critical Care and Cardiac Anesthesia Fellowships at Penn. He'll be speaking on Beyond the Swan, arterial-based hemodynamics in the modern OR. Please join me in welcoming Dr. Feduska.
Thank you very much for that introduction. It's nice to be here. Good to see familiar faces and old friends, and I appreciate being given the opportunity to talk. So today's talk is designed to challenge how we think about intraoperative hypotension. I'll walk through how newer arterial-based monitoring technologies, particularly FlowTrack platform, can help predict, characterize, and treat hemodynamic instability in real time. I don't have any financial obligations with Edwards and no incentive to promote FlowTrack beyond liking the product. So my goal is to give you a framework for interpreting this data, as well as show that with its use, and that instead of reacting to low blood pressure, we can anticipate it, better characterize it, and intervene in a more physiologic and patient-specific way. Okay, so first let us characterize intraoperative hypotension. What is it and how often does it occur? This study published by Shaw and colleagues in 2022 looked at over 22,000 ASA 3 to 4 patients undergoing moderate to high-risk non-cardiac surgery across 11 centers. All of these patients had invasive arterial monitoring, and the surgeries lasted roughly 3 hours or more. Hypotension was simply defined a MAP greater than 65 or a MAP less than 65 for 1 minute or more. So this clinically relevant and commonly cited cutoff is routinely targeted, and yet despite invasive monitoring, the results were striking. So as you can see here, 88% of patients had at least one episode of hypotension below 65, so it's about 9 out of 10. Also note that this rate of hypotension wasn't isolated to one center or a fluke in numbers. Across centers, the rates range from 83 to 92%. Furthermore, the duration of hypotensive periods throughout the case was also disquieting. On average, patients spent about 28 minutes below a MAP of 65. It's the cumulative time, but that's just the average. And as you can see from the center-by-center breakdown, there's a wide range from 22 minutes to more than 30 minutes. And don't forget the standard deviation here is large. Some patients spent far longer with lower blood pressures. So what does this mean for us as anesthesiologists? Even in the setting where every patient has an arterial line, hypotension is pervasive, prolonged, and oftentimes under-recognized. This study really underscores that traditional monitoring alone is not enough. It challenges us to think about proactive strategies. This is where advanced monitoring, hypotension avoidance protocols, and decision support tools may offer real value in changing some of our outcomes. So we've covered that intraoperative hypotension is common, but the real question is, what are the consequences? On the left is a surface plot from Staplefelt and colleagues, which shows how the odds of 30-day mortality climb as depth and duration increase. The red demarcation line there in the center of the scatter plot marks a 20% increase in mortality and connects all combinations of MAP depth and duration that result in a mortality effect. So at a MAP of about 60, for example, you see you need about 30 to 40 minutes below this threshold to hit the 20% mortality increase. Notice though how quickly the line rises once the MAP drops below 55. At this blood pressure, duration of only like 10 to 15 minutes yields the same 20% mortality increase. And it kind of goes across the board. So there's no cliff where the risk suddenly starts. It's a continuum. And the longer and lower the patient's hypotensive, the worse this risk becomes. On the right-hand side is a heat map from Wesselink and colleagues pulling data from 42 studies. It breaks things down in an intuitive way and shows us kind of similar results to the former study. So if you look at the changes of the odds ratio for AKI, myocardial injury, and mortality, as MAP decreases and time increases, at a MAP less than 65 for just 10 minutes, we see the risk of all three starting to rise. Drop below a MAP of 55 for 20 minutes, and the odds of AKI double. Fall below a MAP of 50 for just 10 minutes, and myocardial injury quadruples. And below a MAP of 40 for just 5 minutes, the risk of all three skyrockets. So the message is the same from both studies. Hypotension's toxicity is dose dependent. It's not just whether a patient dips below 65, it's how deep they go and for how long. And once they fall into the danger zone, even short periods carry harm. This is why we need to focus Can't just be on treating hypotension. Once it's established, we need to move forward towards prediction, prevention, and early intervention. So we've established that hypotension causes harm, but for us to effectively treat it, we need to better understand it. So this study by Coos and colleagues, published in the British Journal of Anesthesia in 2023, took a really innovative approach to classifying hypotension. They asked, is intraoperative hypotension really one single phenomenon, or are there distinct patterns hidden underneath? They applied machine learning to large cohort of patients undergoing major abdominal surgery, clustering episodes of hypotension by their hemodynamic profiles. What they found were 6 different endotypes shown on this spider plot. The axes represent heart rate, cardiac index, stroke volume, systemic vascular resistance, and pulse pressure variation. Each colored line represents a different hypotension endotype, and the value for each variable is normalized. The spike or dip away from the 0 helps you fingerprint the dominant physiologic derangement in that endotype. So the key message is this: hypotension is not monolithic. The underlying mechanism matters. We shouldn't see low MAP and reflexively give phenylephrine, and that's where advanced monitoring can come into play. It can help delineate the physiologic fingerprint behind the number so our interventions can be targeted rather than reflexive. Rather than treating the number, we can treat the physiology. So, let's see if I can get the other one to play too. Okay, good. So the clips seen here are from a study conducted by the clinical staff at Edwards. It's a 70-kilogram Yorkshire pig. They had monitoring that included an Acumen arterial line, a Swan-Ganz catheter for macrohemodynamics, as well as a dark field microscope to visualize the pig's enteric circulation. The investigators then did a stepwise hemorrhage and documented the changes that occurred. The clip on the left is normal enteric blood flow. The flow is continuous, the villi are well perfused. The clip on the right is the final stage of the test with 1 liter of blood loss, or about 20% total body EBL. At this stage, they also added phenylephrine and deliberately administered it to mask the effects of the hemorrhagic shock, which you're seeing in clip 2. So shockingly, the macrohemodynamics were pristine. So the Swan numbers were normal. The arterial line was normal. The stroke volume variation was subtly elevated, but nothing dramatic. But the gut tells us a different story. The villi were in a 0 flow state. No blood is moving through the microvessels in the second clip there. The villi are pale and malperfused. The cells are swollen and distended. And the only motion that you're seeing kind of on the top portion of that screen there is external blood in the field. So here the takeaway is clear. Macro doesn't equal micro. Vasopressors can normalize the monitor, but at the price of strangling the tissue. And in this case, the GI tract was taking an unrecoverable hit. Of note, and as kind of a teaser of things to come, during the stepwise bloodletting that they did, the hypotension predictive index was the only indication that something was amiss. So now that we've defined the scope of the problem, that intraoperative hypertension is common, harmful, and often hidden, let's shift into the next part of the talk, how we actually identify and manage hemodynamic instability. And here's the key takeaway. The cause is complex, but the treatment's relatively simple. On the causation side, the pathways are diverse, but the final common pathway is the same, a reduction in cellular perfusion. On the management and intervention side, however, our toolbox is fairly straightforward. We have fluids to restore volume, we have vasopressors and inotropes to support vascular tone and contractility, and we have blood for impaired oxygen delivery. So while the underlying physiology may be complex and multifactorial, our treatment algorithm is built on a relatively small number of levers. The challenge is knowing which lever to pull for which patient and when. And that's where advanced monitoring predictive strategies become invaluable. So how do we tackle this complex issue? Rather than adding more monitors, what if we could extract more information from the ones that we already have? What is often overlooked and what FlowTrack and similar devices exploit is that an arterial line is much more than just a continuous blood pressure tracing. The waveform tells a physiologic story. This slide illustrates how much information is actually hidden in an arterial pressure waveform. So here we see simulated changes in preload, afterload, and contractility. With these changes, the shape of the waveform changes in recognizable ways. In preload deficiency patients in blue, the early systolic upstroke is blunted, the downstroke is steeper, and the dicrotic notch appears earlier. In contractility deficiency in orange, the changes are subtler but still visible. The systolic rise is gentler, the peak pressure is reduced, and systole is prolonged. And in afterload deficiency, The later part of the waveform changes and pulse pressure widens. There's brisk ejection with a rapid runoff. So why does this matter? Because the devices like FlowTrack, like I said, exploit these waveform features. They use proprietary algorithms that continuously analyze the contour of the waveform to estimate stroke volume, cardiac output, and additional dynamic indices we're going to discuss. This is how we move from simple blood pressure tracings to advanced monitoring by decoding the signatures hidden in the arterial waveform itself. So how does FlowTrack actually take this arterial waveform and turn it into something that's clinically relevant for us? It starts with the basic principle we saw on the last slide, which is pulse pressure is proportional to stroke volume. You multiply stroke volume by heart rate, you get cardiac output. But the relationship between pulse pressure and stroke volume isn't fixed. It depends on the vascular compliance and resistance, which vary from patient to patient. That's where FlowTrack's proprietary algorithm comes into play. The system samples their arterial waveform at a very high frequency, 100 times per second over 20 seconds, giving about 2,000 data points, and analyzes the contour in detail. By combining the patient-specific factors of age, sex, height, and weight that you put in, the continuous waveform analysis, the device calculates the hemodynamic metrics. So before we move into the nuances and limitations, let's pause for a quick summary of what FlowTrack's pulse contour algorithm actually is. So you have the input signal, which is the arterial pressure waveform. It's most commonly obtained from the radial artery, though alternative sites can be used. What's important is the fidelity of the waveform, not necessarily the location. From that, the algorithm generates several output metrics, so stroke volume, cardiac output, stroke volume variation, EA dyne, DPDT, and the HPI. One of the key features is that there's no calibration required. Some other systems do require calibration. FlowTrack's uncalibrated and relies on its proprietary algorithm to self-adjust. So in short, it's easy to set up, doesn't require calibration, and gives you continuous advanced hemodynamic data directly from the arterial waveform itself. Now that we've reviewed what FlowTrack measures, the question is, how do we actually use the numbers to optimize fluid management and patient perfusion? So I'm going to breeze through the basics of stroke volume variation, cardiac output, and SVR. So stroke volume variation, our marker of fluid responsiveness, when it's elevated, typically above 13%, volume is likely the way to go, or the patient should be fluid responsive. Cardiac output, a low cardiac output could mean volume, inotropes, or both. And then systemic vascular resistance, which helps tease out whether hypotension is primarily vasodilatory or flow related. I think the real value comes as we layer in some of the less familiar metrics on top of the metrics I just discussed. So EA dyne, DPDT, and the HPI, which gives us more nuanced, actionable insight in real time. So the EA dyne, it's an elegant measure of arterial tone. It tells us whether giving fluid will also improve MAP or just the cardiac output. A high EA dyne, typically greater than 1, indicates that the patient's arterial system has sufficient tone, and fluids alone are probably appropriate in the situation. A low EA dyne, less than 0.8, suggests that fluids probably won't cut it, and you're likely going to need a vasopressor to facilitate the patient's SVR. And then when you're in between those two values, 0.8 to 1, you're kind of in a gray zone, so you use your best clinical judgment, take everything into consideration, and use the other parameters that you have at your disposal to treat the patient. Next, DPDT. This serves as a surrogate for left ventricular contractility, refining a low cardiac output or index state. For example, someone who may benefit from inotropes rather than just additional volume. And finally, the HPI. It's a preemptive tool. It gives us a score from 0 to 100, predicting the risk of hypotension before it happens, allowing us to intervene rather than reacting after the fact. Taken together, these parameters, Taken together, these parameters give us the decision-making framework. Is the problem preload, afterload contractility, and with the HPI impending hypotension? Once we've identified the underlying pathophysiology, we can then pull the right lever and intervene. So let's turn now to the HPI. So HPI was derived from high-fidelity waveforms in over 1,600 surgical patients and ICU patients. The developers extracted more than 3,000 waveform features like the ones that we discussed in slide 7. The algorithm then looks at how those features are trending in real time when the pattern of the waveform starts to resemble what it looked like in thousands of patients just before they became hypotensive. When this occurs, the HPI then starts to rise. So in other words, it doesn't predict hypotension by extrapolating the map. It predicts by recognizing the signature of instability in the arterial waveform itself. So why does this matter? Because HPIs consistently outperform traditional hemodynamic variables, things like we discussed, MAP, stroke volume variation, cardiac output, particularly in the operating room and in the ICU setting. So I think I already mentioned it, but it's a scale of 0 to 100. It reflects the probability of hypotension, MAP less than 65, for at least 1 minute, and it has a horizon window of typically 5 to 15 minutes. And the values, the kind of general cutoffs, are greater than 85, the patient's going to be high risk, actionable threshold to intervene. 70, 80 is a bit of a gray zone. Continue close monitoring, see how the patient's doing, use some of your other variables. If you're less than 50, the patient's hemodynamically stable and pretty low risk for anything happening in the next 5 to 15 minutes. So I think it's easy to think of the HPI as the pulse oximeter of hypotension with the good and bad reversed in terms of the numbers. So we've seen how HPI has been built, but the question is, does it really work? This paper by Davies and colleagues in anesthesiology in 2024 is the most rigorous validation of it to date. They compared two designs, a backward case control approach where you start at the hypotensive event and work backwards, and a prospective forward cohort design where you begin in normotension and predict what's coming down the pike. Said another way, the backwards or case control design shows whether HPIs rise before hypotension occurs, and with the forward or cohort design, they flip the perspective starting from normotensive periods. They follow the patients forwards in time to see if the HPI predicted an upcoming hypotensive event. They did this to test whether HPI is specific enough to avoid many false alarms. What they found was striking. In both of these designs, the discriminative ability of HPI was extremely high, with areas under the curve of 0.92 to 0.95 for predicting hypotension at 5, 10, and 15 minutes, as seen in the bottom table there. The scatter plot on the right reflects the overall behavior of HPI across the entire data set and effectively illustrates that once MAP begins to trend downward, HPI climbs steeply, giving advance warning that the patient is about to cross into the danger zone or the MAP less than 65. So the bottom line is, no matter which way you look, backward from hypotension or forward from stability, HPI is robust, consistent, and reproducible. More succinctly put, HPI tells you when to look, and as we reviewed, physiology tells you what to do. So device limitations. As we wrap up here, it's important to acknowledge the limitations of FlowTrack in arterial-based monitoring. Like any technology, it provides estimates based on assumptions about the circulation, and when those assumptions are violated, errors can occur. For example, in regurgitant lesions or hyperdynamic states, the device tends to overestimate cardiac output because it counts regurgitant or ineffective flow as forward flow, and fixed outflow obstructions like aortic stenosis or pulmonary hypertension. Stroke volume and contractility can be underestimated since pulse pressure no longer reflects true output. Because SVR is calculated from cardiac output, errors there propagate forward, often leading to SVR being underestimated. Similarly, DPDT is not a pure measure of contractility. It can be influenced by arterial compliance and waveform transmission. The HPI is powerful, but it can't predict, it can't model every possible waveform pattern. So arrhythmias, RV failure, artifacts can limit its accuracy. Finally, indices of arterial elastance and dynamic preload, like stroke volume variation or pulse pressure variation, lose reliability in patients with stiff ventricles, pulmonary hypertension, or irregular rhythms, like the ones Gina was discussing. So while these tools are enormously helpful in most patients, we need to keep their blind spots in mind. They're best used as part of an integrated picture, combined with clinical judgment, echocardiography if need be, and an understanding of the patient's pathophysiology. So summary key points for this: hypertension is common, harmful, and can be reduced. Hemodynamic instability, pathophysiology is multifactorial. Treatment of hemodynamic instability should be correlated clinically and addressed causally. And machine-based learning arterial waveform analysis can help prevent or treat the underlying cause of hypotension and hemodynamic stability. And with that, that concludes my portion of the lecture.
Thank you. Very exciting, especially as we look towards trying to figure out how to better monitor and better care for patients as they become sicker and sicker. I'd like to open up, if anyone has a question they'd like to ask one of our panel members, please raise your hand, and I'll get mine ready here.
Okay, there it is. Hey, I had a question regarding FlowTrack. It sounds like all make sense, like how useful it is? Are there maybe cases where, aside from what was mentioned in the slide, where maybe you'd say, hey, I could use this, like theoretically, if they have an A line and all those parameters are met, you can place a flow track, but are there maybe cases where you'd say, this might be kind of overkill, or maybe we could use it, but we can probably just use the A line as it is for now as an effective enough parameter?
It's a good question. I think the rate limiting for a device like this is basically, do you have it available to you? So I would say if you had the luxury of limitless resources, you had an arterial line in place, I would certainly use the flow track system and just keep these kind of limitations in mind, because basically the same pathophysiology that's going to impact flow track is basically going to be impacting your arterial line. It's just a matter of understanding what the patient's pathophysiology is. So I don't necessarily think it would be overkill in any situation, because you already have this line in place. You're not doing any additional interventions. You're just using data and resources that you have at your disposal.
And it's a great point. And so, Dr. Feduska, moving away from individual measures of hemodynamics as we differentiate shock and things like that, and we provide pulse pressure variation from our art lines directly on our Philips monitor, and we used to use the LIDCO device to give us that data. But now we have pulse pressure variation. I'm curious your thoughts on using that intraoperatively for volume responsiveness, given that a lot of the evidence we have on PPV is built from, say, critical care patients with a very rigorous set of criteria, right, to determine its effectiveness.
Yeah, I think that any additional hemodynamic variable is better than not having it. So I think it's worth using PPV, but again, just keeping in mind what the potential limitations or pitfalls with it are. I think oftentimes you can use the trend as well to kind of help aid in your decision making.
Right. Yes.
Thanks for a great talk, guys. About the hemodilution, any evidence that it's being used for other bloody surgeries like spine or liver or things like that?
Not to my knowledge. One of the major benefits of the acute normovolemic hemodilution is that you're sparing that blood from contacting the cardiopulmonary bypass circuit. In a spine surgery, yes, you have your cell saver and all that kind of stuff, but you wouldn't benefit from one of the things that's the most important thing that you're benefiting from. I'm sure that that some of the one of the papers I showed you did say that they had less blood loss. So maybe there's a role for it, even in that context. But I think the major benefit that we see in our population is from not contacting the cardiopulmonary bypass circuit, which you would not benefit from in a spine patient.
So actually, we do use ANH. Well, I'll talk about that in a second. We use bloodletting for our some of our liver cases when the hemoglobin is a certain threshold in the MELD. But we don't replace it, so we don't do the normal volemia or the hemodilution, right? We just take blood away with the thought, I think, to reduction of CVP is going to be helpful in those liver cases, and also you'll be able to give potentially their blood back and reduce the risk of allergenic components. So I guess that was my question to you. Do you feel that some of the important aspect of that is to maintain the circulation, and do you intentionally hemodilute patients if they don't look like they need it from, say, a hemodynamic standpoint?
Not if you're saying if I think someone has a high CVP, would I reflexively?
My understanding is some of the fundamental benefits is you bleed blood that's a little more anemic than your normal blood, right? If you restore the circulation to, say, a hematocrit of 28 from 40 or 35 or whatever, that you're actually losing less blood. There might be some benefit in that, but I don't know if that's a part of the protocol. Or
yeah,
design.
I mean that's certainly one of the benefits, and I think the benefit that you could justify using it in a case like a spine case. The other thing too is that I've heard some people suggest, and I haven't seen any much evidence of it, that by decreasing the viscosity of the blood, it might help forward flow of the blood through the microvasculature as well as the cardiopulmonary bypass circuit. Again, with that, you're decreasing some of your red blood cells to get that viscosity, so your oxygen delivery might be hindered. So it's a balance. But for patients with poor microvasculature, maybe a little less viscosity to the blood might be beneficial for delivering oxygen.
that done with the entire circuit already primed with either normal saline or LR? And if it is, how much does come back into that bag, that reservoir, before you say, okay, it's probably pretty concentrated at this point, the piping or the circuit is now mostly blood and not saline?
Yeah, so it is full. They do prime it with saline first. You're not looking for necessarily concentration to tell you to stop. You're looking to see if there is dark red blood in replacing where there once was clear saline. Generally, about a half a liter of saline they can remove off, so it's not insignificant. Sometimes more. Right? Yeah.
I think it also depends if you're using like one of the microcircuits. It depends like what side circuit, but the perfusionist will know how much volume is in the tubing. So the tubing that goes from the circuit to the aortic cannula, the tubing that goes from the circuit to your venous cannula, there's a number. So depending on what size circuit you use, and are you bicavally cannulated? Do you have a single atrial cannula? That number is all known, so the perfusionist will know how much blood to take back from that.
Gotcha. And there has to be that saline in there initially, just in case for any reason you needed to turn on the bypass machine, you could do it without risk of venous air embolism.
Correct.
Okay.
Because you can't, if you have air in your tubing going to the aortic cannula, if you needed to go on, then that air goes right to the brain. And
Yeah. Okay.
Your thought process is exactly correct. That's why you would do it. Yep, exactly.
Okay. Thank you.
Any other audience questions? All right, Dr. Lingan, I'll put you on the spot here a little bit. Oh, you ready? You got one?
I had one last question about arrhythmias. So I've had a couple of cases where like the patient will be normal sinus rhythm, everything EKG looks fine preoperatively, but then intraop they will flip into like a spontaneous left bundle branch block. Looks okay otherwise on tele, no issues, and then it'll flip right back to normal sinus rhythm, no other issues. I've talked to a couple of attendings, and one time we even consulted cardiology, and they also were like, we don't see it too often. It seems to just kind of go away on its own. I was wondering if you've seen it before, or if you've had any experience with that, what it's looked like at your institution. Because sometimes it just kind of perplexes some of the attendings.
it's funny that you mentioned that, because that exact situation happened to my colleague like 3 weeks ago. And normal sinus rhythm, and then flipped into left bundle during the case, hemodynamically insignificant. I think the patient, I want to say they were in like their 50s, so not at no risk for having a myocardial event. And we're like, you know what, if it flips back and nothing happens, we're just going to write it off as anesthesia. We don't know everything about anesthesia yet. We'll just write it off. Flip back again into the bundle and PACU. They're like, you know what, let's just send tropes. Trope or bumps, went to the cath lab, had a new MI. So yeah, I would say if it flips back and everything's fine, the patient's asymptomatic. And this lady, I think she was having a little chest tightness, not chest pain, didn't feel like an elephant was sitting on her chest, but or maybe she said she was having reflux symptoms. She was a woman, right, so it presents a little atypically. But the fact that it was persistent, and so tropes, cath lab, the whole 9 yards. So I would say it's definitely not something to write off. But if it reverts back to normal, it's probably not worth going down the whole cath lab cardiology rabbit hole when you might just find might be like an incidental loma. But if it like persists and you have like your spidey senses go off for any reasons, I would say work it up. And that's what my colleague, he ran the case by me, and I was like, I wouldn't let it go. Like something just seems off about it, and it turns out he was correct.
Great. Any other questions? I was going to close it with adenosine. So it's my second least favorite thing to do is push adenosine. My least favorite thing to do is virtually instruct someone to push it when you can't see the patient or the rhythm. We staff a rapid response team, so we'll get these calls sometimes, and the lead off is, I want to give this lady adenosine. And somebody's having to talk people down from that, and I'm just curious, is that fear warranted? Have you encountered negative experiences or times where you pushed it where you wished you hadn't?
I have been fortunate enough that other than my heart rate, like making up for the patient's lack of heart rate, I have never had any bad experiences with adenosine. I've either had it do nothing and they go back into whatever rhythm they were in, or I've had it break. But I've been fortunate I've never had a bad incident. I will say one thing that I've learned from pushing adenosine is to make sure everyone in the room is on the same page, that we're all going to be a little worried and it's okay, especially when you're working trainees or like, I don't know about you guys work, like all of our nurses are like 21, so they've never seen adenosine pushed. So they just like warning everyone in the room and getting everyone on the same page, like, hey guys, this is going to look really bad for like a very, very long 5 seconds. But I don't know what your experience is. I've never had a bad thing happen with adenosine.
Yeah, just a point. Yeah, for the junior learners, the contraindications are often overlooked when you're responding to someone with SVT that you don't know. You're not entirely sure how they got there, and yet you're making this decision. There's some medications involved and some baseline characteristics, but it can be tough when someone's confronted with that and wants to just try to break it. So.
Exactly. No, that's exactly it. For people who couldn't hear. If you're not sure if it's AFib versus SVT, adenosine will make that diagnosis for you.
Mm-hmm. Great. Well, we still have another minute or two if anyone has thought of anything, but otherwise, I think timing was pretty good today.
Oh, sure. The question was, why do you see a higher incidence of AFib coming off of bypass? So there's actually, I think there are guidelines that were published, I want to say like 2015, 2016, that talk about the incidence of AFib coming off cardiac surgery. Cardiac surgery itself is a risk factor for AFib. I don't think, and you guys can correct me, I don't think there's a known mechanism as to why that is the case. One of the proposed mechanisms is just mechanical irritation to the heart. One thing that we see in people who go into AFib before bypass are much more likely to have AFib coming off bypass. People whose hearts are, it's probably not the most politically correct word, but like when we call their hearts a little sensitive. When they're a little sensitive before bypass, they tend to be a little sensitive and more prone to arrhythmias coming off bypass. There are things we can do to prevent it, like certain patient populations will get amnio started immediately. I would say like in mitral valve surgery, at least at Penn, we have a lower threshold for starting amnio than in other, like cabbage or something like that, and then get them on their beta blockers pretty quickly. I don't know if you guys have different experiences with AFib.
No, the incidence of AFib in the ICU after cardiac surgery is extremely high. Like a very high percentage of patients will get it. So we at Jefferson, a little bit different than what we did at Vanderbilt, will just and I think this is what you were saying, like reflexively put people on an AFib prophylaxis, whether it be amnio if they can't tolerate a beta blocker or a beta blocker, and with I think pretty good result. But yeah, it's a whole multitude of things. I think a lot of people think it's like cellular swelling secondary to surgery, mechanical irritation, changes in ventilatory mechanics causing minor variations in oxygenation. Same thing, same reason you see AFib patients that are like COPD or whatever, and then electrolyte abnormality. So I always try to keep the potassium over 4 before leaving the operating room, because even if patients are used to 4.5 and now they're 3.5 after a 2-hour period of time, that could be significant enough to cause someone to go into atrial fibrillation. But yeah, I don't know if anyone can really put their finger on exactly what causes it.
Thank you, everybody. That's the end of today, and I guess there's activities to follow.